Hello everyone, I'm Linkis Shanmugam and I'm going to explain about the case 3 which is about the hypertensive emergency with the left basal ganglia hemorrhage. So, this is the patient demographic and background with the chief complaint and history of present illness. The questions are summarize this case, explain the indication of the medication in the ward and the lab parameters, and discuss in detail the management of hypertensive emergency in this case. So, the summary of the case is the patient name is Mr. MS, who is a male with 60 years old and has been diagnosed with hypertensive emergency with the left basal ganglia hemorrhage and also upper gastrointestinal bleeding secondary to stress ulcer. The patient, the medication given upon the admission for the patient on the 2nd December were intravenous labetalol and also intravenous tranexamic acid. The patient's past medical history was the patient had underlying hypertension. Well, based on the lab test, it has been observed that the platelet count for the patient is lower than the normal range, and this is probably due to the overconsumption of NSAID. Based on the observation, it has been known that the patient had a very high systolic blood pressure and also diastolic blood pressure, which indicates that this patient had a very high blood pressure, and this might increase at 30% of the major cardiovascular risk events in the next 10 years. So, the patient also had left basal ganglia hemorrhage, which is a type of stroke. This indicates that the patient has one of the target organ damage. So it has been confirmed that this patient has a hypertension with an organ damage, which also known as hypertension emergency. So these are the indication of the medication that have been given in the ward for the patient. The first is intravenous labetalol, which given for the management of hypertension crisis, which means the hypertension emergency. And the intravenous tranexamic acid was given in order to control his intracranial bleeding, which is the left basal ganglia hemorrhage. The third is IV midazolam was given to cause drowsiness to the patient and relieve the anxiety due to the hypertension emergency. And it is also effective in lowering the blood pressure effectively. Fourth is IV erythromycin ethylsuccinate (EES), which is an antibiotic prescribed to treat the bacterial infection for the patient. And the fifth is pantoprazole. It was prescribed in order to reduce the gastrointestinal bleeding since the patient had upper gastrointestinal bleeding secondary to stress ulcer. Sixth is maxolone. Maxolone is actually a metoclopramide which was given um, as an antiemetic, as the erythromycin ethylsuccinate can cause nausea and vomiting. Captopril and pramipramine is an angiotensin-converting enzyme which act as a first-line therapy for the hypertension. The atorvastatin, which is a lipid-lowering agent, was also prescribed to reduce the risk of cardiovascular events. The prazosin, which is an alpha-1 receptor blocker, was prescribed for in order to cause arterial vasodilation. And lastly, the amlodipine was given as a first-line therapy for hypertension. This is the management of hypertension according to the Clinical Practice Guideline on the 5th edition in 2018. So, the medication for hypertensive emergency are labetalol and also nicardipine. First, in the management of hypertension emergency, we will focus on medication such as nicardipine and also labetalol, which can be prescribed for hypertension emergency. The issues are nicardipine IV infusion and also labetalol 200 mg. The goal of therapy is to reduce the blood pressure and treat the hypertension emergency and also to reduce the blood pressure by 10 to 20% within certain minutes to hours, but not lower than 160 over 90 given with parenteral drugs. Based on the literature, which was conducted in a retrospective analysis of consecutive patients receiving intravenous labetalol or intravenous nicardipine in the intensive care unit with acute elevation in either systolic or diastolic blood pressure, the patient demographic clinical characteristics and the short-term clinical outcomes were abstracted from the medical record. So, Based on this literature review, it has been known that the proportion of the patient achieving their blood pressure target was significantly greater with nicardipine with 83% than with labetalol 67%. The proportion of patients requiring an alternate antihypertensive agent was significantly greater with labetalol than nicardipine. The total number of all-cause adverse events was significantly greater with labetalol than with nicardipine. Thus, labetalol was associated with significantly greater incidence of hypertension and bradycardia, and there was no significant difference in the frequency of other adverse events between these two drugs. The median hospital costs were not significantly different between patients receiving labetalol and patients receiving nicardipine. So, based on the literature review, we can say that nicardipine and labetalol are effective as in they are able to treat the hypertension emergency. Next is drug-related problems. The first is inappropriate choices of statins. The issues are atorvastatins interact with amlodipine, which can increase the bioavailability of atorvastatin and causes side effects such as rhabdomyolysis. Atorvastatin does not undergo an extensive pre-systemic metabolism such as lovastatin or simvastatin. Potent cytochrome P453A4 tends to produce 2 to 4-fold increase in atorvastatin Cmax concentration. So combining statins with cytochrome P450 inhibitors undergoes extensive pre-systemic metabolism in the gut wall and liver. The goal of therapy is to reduce the cardiovascular events for the patient as he is an active smoker and to avoid the error through potential drug interaction between atorvastatin and amlodipine. So this is the literature review which mainly shows the combination of dihydropyridine (CCB) with statins, then used in the condition for the patient with high cholesterol or hypertension. In order to reduce the risk of myopathy, the FDA set a new dose limitation for simvastatin for patients who were also taking amlodipine. So, the risk of statin-induced myopathy due to cytochrome P450 inhibitors appears considerably greater when taking lovastatin and simvastatin compared to atorvastatin. The atorvastatin does not undergo an extensive pre-systemic metabolism such as lovastatin and simvastatin. So, this case illustrates that when high doses of atorvastatin are co-administered with amlodipine as a secondary prevention of cardiovascular risk, the combination may pose risk for serious myotoxicity such as rhabdomyolysis. Another literature review has been observed which shows that a total of 1,182 patients were randomly assigned to receive either atorvastatin 10 mg or rosuvastatin 5 mg or 10 mg in the three trials comparing the two drugs. The 12-week efficacy analysis involved 1,172 patients, in which 4 patients in the rosuvastatin 5 mg group, 3 in the rosuvastatin 10 mg group, and 3 in the atorvastatin group were not included in the efficacy analysis due to the non-compliance with study medication requirement or the lack of baseline or post-baseline measurement. So, when rosuvastatin, the both 5 mg and 10 mg used together, the percentage reduction in LDL cholesterol from the baseline significantly higher than the atorvastatin 10 mg. So, this indicates that rosuvastatin was favored over atorvastatin in statistically significant differences, with exception to with exception to triglyceride, which did not differ significantly. Another literature review also shows that co-administering amlodipine, valsartan, and rosuvastatin to healthy volunteers result in a decrease in the pharmacokinetic exposure to valsartan but did not alter the exposure to amlodipine and rosuvastatin. So based on the literature review, we can recommend that atorvastatin can be changed to rosuvastatin as the interaction between rosuvastatin and amlodipine not as any clinically significance. Another drug-related problems are incorrect prescription of prazosin. Prazosin can cause orthostatic hypertension, especially in elderly patients. Since the patient is 60 years old and considered to be elderly, prazosin is not the appropriate medicine to be prescribed, and it is not a first-line therapy in treating hypertension emergency. Moreover, the sensitivity to the product is conserved in elderly people. As with other alpha-1 receptor blockers, orthostatic hypotension has been described, mainly due to impaired baroreflex activity. So, the goal of therapy is to avoid the risk of first-dose hypotension and orthostatic hypotension in patients. So, based on the literature review, it says that the study was carried out in the 9 hospitalized patients, with 7 males and 2 females, aged from 15 to 60 years old, suffering from mild, moderate, and severe essential hypertension. Renal impairment had been ruled out by routine analysis. They had not been previously treated or had stopped taking hypertensive therapy at least 1 week before admission to hospitals, and daily dietary sodium intake was from 150 to 250 microequivalents. So it is recommended that it is best to begin with a low dosage, which means 0.5 mg 3 times per day, and stick with it for a week. After that, the dosage can be raised until the blood pressure is under control. Taking the first dose in the evening is recommended due to the possibility of severe hypotension. Next is incorrect medicine prescription for the patient. Well, the issue says captopril used widely in treating hypertension urgency and not hypertension emergency. The goal of therapy is to avoid taking captopril for the patient with the hypertension emergency and also to avoid excessive hypertension in elderly patients. This was a cross-sectional study which involved 50 patients attending a selection of Gotham State Hospital Emergency Center with a clinical diagnosis of hypertension urgency were approached by investigators for the study. The dose regimen, prognosis, and the reduction in the systolic and diastolic blood pressure were collected alongside a questionnaire to patients regarding their care, and the data were analyzed using the chi-square test to compare the mean difference of various results. The difference were considered to be significant at p less than 0.05. So it has been recommended that it is better to discontinue the captopril for the patient and is not appropriate and cause excessive hypertension in the elderly patient. So these are the references that has been used in order to study this case report. Thank you.